Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you very much for joining. And my name is Naveed Rahman Siddiqui. I'm working as pediatric intensivist at Khan University Hospital. And in the next 15 to 20 minutes or 25 minutes, we'll be discussing about basic concepts of oxygen care and how it affects the ICU patients. I have no disclosure for this presentation. The learning objectives now will be to understand the concept of oxygen delivery, oxygen demand, oxygen depth, oxygen consumption, and oxygen extractions now, which will going to help you understand how oxygen is important and how it is important in patient care while looking after ICU patients. So it is of critical importance that is body require oxygen delivery to meet the demand of the tissues. And the first thing which was being asked told us in our ICU fellowship that you need to deliver the oxygen. You need to improve the oxygen delivery to the farthest organ, to the heart, that is to the each and every cell of the body, to each and every organ of the body, in order to support them. How you are going to support each and every organ of the body in critical illness, and how it needs to be supported to provide them adequate oxygen delivery for that part. And it is inadequate oxygen delivery that must be recognized, and it should be treated in order to achieve a good clinical outcome. A global level, it can be inadequate oxygen delivery can be a global level, that is, it can be related to any kind of shock leading to diffuse hypoxemia throughout the body, in which other organs are being involved, leading to multi-organ dysfunction, like in cardiogenic shock, like in hypovolemic shock, like in distributive shock, which involve different organs of the body globally. And it can be at regional level, like it occurs in traumatic brain injury, like it occurs in acute kidney injury, like it occurs in myocarditis, like it occurs in acute lung injury. So all these other organs can be deficient in oxygen delivery, and in those, how you can improve those regional oxygen delivery in these patients, that is of prime importance. For that to understand, you need to understand the determinants, that is what is oxygen delivery, what is oxygen consumption, which is really important concepts when you are dealing with critically ill patients. And a critical care physician, it is essential for them to know about it. So for the gas transport, this is just a generalized concept that people, when you breathe air, it goes into the lungs, and that is, you breathe in oxygen and you exhale out carbon dioxide, and in the lungs, it is gas exchange occur at the level of the alveoli, where oxygen is being absorbed into the blood and carbon dioxide is being released into the lungs, and then this oxygen goes into the left side of the heart to the rest of the body, where this oxygen is being delivered to different tissues of the body and vital organs, where it is being oxygen it is metabolized and utilized to produce energy. And then CO2 is being released from the tissues, and it is being carried by the blood into the right side of the heart, and from where it went, it goes back into the lungs, and the CO2 is being washed out. So this is all the gas transport which occurs within the body, and that is pretty important to understand. How does the alveolar gas exchange occurs? As the venous blood comes, it is rich of carbon dioxide. It is less. It has less oxygen, as it is being mentioned in these graph as well. As it reaches the capillaries, where the gas exchange occur, after the gas exchange occur, oxygen is being attached to the hemoglobin, and carbon dioxide is being released. So when it leaves the lung capillaries into the arterioles, then into the pulmonary veins, then it is much oxygenated, and the oxygen is high, and CO2 goes down in the arterial blood samples. So how the impaired gas exchange occur at the alveolar level? There are 2 or 3 mechanisms through which normally, if the blood supply is being adequate and if the alveolar space is being adequate, then the gas exchange usually occur in a normal way, and there is adequate ventilation, and that is ventilation is being adequate, air is being going into the alveoli, and perfusion is being adequate, that the blood is being going through, and there is adequate gas exchange. However, there are different mechanisms. If there is no blood flow to the vessels, although the air is being coming into the lungs, but it is not being, there is no gas exchange, as no blood is passing through these alveoli, and this lead to functional dead space ventilation. There is no gas exchange occur in these, and then the blood usually passes through the arterioles without being gas exchange. Then there can be a diffusion barrier, that is if the patient has developed ARDS, if the patient has developed pneumonia, pulmonary edema, or any lung disease that lead to diffusion barrier, which can lead to significant dead space ventilation. That is the air which is being coming into the lung, it is not being exchanged with the blood which is being coming into the lung, and blood usually passes without oxygenation and ventilation, and that is called the alveolar level shunt. In the same way, if there is a mucus plug that is blocking the airway and the alveoli is being collapsed, as you have seen, and it is pretty common in infants that they collapse their lungs and they are not being able to ventilate their lungs. So the blood passes through these alveoli without any gas exchange, and this is called the shunting. This is another short of shunting. So these are alveolar shunts that can occur, and that can lead to desaturation and further impairment in the gas exchange without an increase in the carbon dioxide and decrease in the oxygenation of the blood. So what is oxygen delivery? The supply of oxygen per unit time or to the tissue, organ, or the entire body, that is called the oxygen delivery. Oxygen delivery, that is how much oxygen is being delivered to the tissues, to the organ, or to the entire body, and it includes, it is a product of cardiac output and oxygen carrying capacity. We're going to discuss this concept and we're going to discuss the cardiac output and oxygen carrying capacity in the next few slides so that you will be clear as well. So what is oxygen carrying capacity? It is the sum of oxygen bound to hemoglobin, and it is the sum of oxygen dissolved in the blood. So in this formula, which shows hemoglobin into 1.34 and saturation of the arterial oxygen, 1.34 is the amount of oxygen which is being attached to the hemoglobin, one hemoglobin molecule, and if it is being multiplied, this gives you the oxygen bound to the hemoglobin, and this is the if partial pressure of arterial oxygen multiplied by 0.003, which is almost negligible. This is the dissolved oxygen in the plasma, and in combination of these, this can define oxygen carrying capacity. Most of the oxygenated oxygen in the blood travel bound to the hemoglobin, only minimum amount travels as dissolved hemoglobin, as it has been obvious with this formula as well. And oxygen content depends primarily on the oxyhemoglobin saturation and hemoglobin concentration, therefore it is of pivotal importance. So this graph does shows oxygen hemoglobin dissociation curve, which you guys must have gone through different during your medical schools, and it does shows how important it is. And if you were going to see the oxygen, you were going to see the oxygen bound to the hemoglobin and the capacity of the oxygen, it is being as the hemoglobin drops down, its capacity goes down as well. If this is the normal oxygen capacity, if the hemoglobin drop down to 6 or 4, definitely that will going to reduce the oxygen hemoglobin capacity. Capacity is being decreased significantly, and in order to increase it, sometimes you need to transfuse them blood so that you can increase the oxygen carrying capacity of these patients, especially in critically ill. It has been recommended if the hemoglobin is less than 7, you can transfuse if there are no contraindication or if the patient is not sick enough. However, if the patient is sick enough, definitely then the patient needs to be transfused the hemoglobin to increase the hemoglobin around 9 and 10 in critically ill patients to improve the oxygen carrying capacity if they have issues of oxygen delivery. This is another oxygen hemoglobin dissociation curve which shows right and left curve. So there are different conditions which can lead to decreased oxygen affinity, that is increased hydrogen ion concentration, increase in RBC to 3 increase in temperature, increase in partial pressure of carbon dioxide, and decreased pH. Now all these lead to decreased oxygen affinity and rightward shift of the curve toward this side. However, it can lead to opposite of it, and if it is being shifted to the left side as well. One thing that is important, hemoglobin F, if it is there, that it has increased affinity to oxygen, and one need to look into, for example, in thalassemia patients, these patients usually have hemoglobin F, and they usually require they have increased oxygen affinity, and they are usually hypoxic. That's why their hemoglobin is, it is really important for them to have this hemoglobin A to be there, and they usually require they have increased affinity, so oxygen delivery has been compromised in these patients as well. Another important aspect of increased temperature that causes a decreased affinity of oxygen as well, that is important. Then comes to the cardiac output. Cardiac output, it is the amount of blood that is being pumped to the systemic circulation in liters per minute, and that depends on the stroke volume and heart rate, and in turn stroke volume is dependent on the preload, afterload, and contractility. So in order to improve the oxygen delivery, it is not only the oxygen carrying capacity that you need to work on, that is you need, as we have discussed in the previous slide, that you need to work on hemoglobin, you need to work on arterial saturation, but at the same time you need to work on cardiac output, that is stroke volume and heart rate. You need to improve the stroke volume, that is you can increase the preload, you can decrease the afterload, and you can improve the contractility to improve the cardiac output in these patients, and in turn that will increase the oxygen delivery to these patients. So what is oxygen demand? The amount of oxygen that a tissue, organ, or entire patient would need to consume to meet all of its needs under given circumstances. So oxygen demand cannot be measured, but it is a useful concept reflecting upon factors that will affect the oxygen delivery and consumption. So for example, if the patient is in respiratory distress and increases the respiratory distress increases the oxygen demand of the respiratory muscles. It has been seen that if the patient is in severe respiratory distress, they can utilize respiratory muscles, subcostal muscles, intercostal muscles, nasal flaring, and that can lead to increase in the oxygen demand almost 40 to 50%, and one can decrease that demand if we can put them on assisted ventilation. That can improve the work of breathing, that can decrease the work of breathing, and that in turn will going to decrease the oxygen demand of these patients, and that will going to improve oxygen delivery and oxygen demand mismatching. So it is not only that you need to work on oxygen delivery, but you need to work on the demand as well, how you can decrease the demand so that you can match the supply versus demand concept. So what is oxygen depth? It is a difference between the oxygen delivery and estimated oxygen demand. How much oxygen is being delivered and how much oxygen is being demanded, what was the demand of it, and the difference of it, and I will going to give you the oxygen depth. When there is a significant oxygen depth, that is there is oxygen delivery is being compromised and oxygen demand is being increasing. So there is a significant oxygen depth, there is increase in oxygen delivery, therefore increase in oxygen delivery will increase the oxygen consumption. And when the oxygen demands are being met, there is no oxygen depth. But however, if the oxygen delivery increases, that will not going to match the oxygen demand, definitely the oxygen depth will gonna increase. However, if the oxygen you increase the oxygen delivery and there is no effect on oxygen consumption, then definitely there is no oxygen depth, and in those scenarios. So this is another important slide that is suggesting that you can work on oxygen delivery, increasing the oxygen delivery in these patients who are in shock, or in those patients who have decreased cardiac output due to any reason, decreased oxygen carrying capacity due to any reason. However, if you are not being able to improve the oxygen delivery, you can at least decrease the demand, oxygen demand, by keeping them sedated. For example, if a patient is being admitted with bronchiolitis, he's been working pretty hard, as well as you have started them on high flow, the child is pretty irritable and they are not well sedated, then that irritability will going to cause increased oxygen demand, and if the child is not being able to meet that demand, the child will deteriorate and will go into shock. So in order to prevent that, you can start them on sedation so that you can make them quiet and calm, and that demand is being decreased, and you can then help matching the oxygen delivery and demand accordingly. For example, if the patient is being put on assisted ventilation, as well as if the patient is being in shock and you are not being able to increase the oxygen delivery, you can make them sedate, relax, in order to decrease the oxygen demand of the child and metabolic demand. You can start them. You can consider barbiturates. You can start them on hypothermia. If there is fever, you can treat that fever. If there is infection, you can treat that infection. You can treat agitation. You can treat seizures. You can improve the oxygen, increase work of breathing by putting them on assisted ventilation or invasive ventilation. And you can use positive inotropic support in order to for the heart to work adequately and to improve the cardiac output, to improve the oxygen demand. So oxygen consumption versus oxygen delivery relationship is really important. What is oxygen consumption? It is the oxygen utilized per unit time by a tissue, organ, or entire body. And it does shows that if you're going to see the normal relationship of oxygen consumption and oxygen delivery, it is supply dependent to a certain critical point. And it is at that critical point when the supply is met, you can see further increasing the oxygen delivery does not increases the oxygen consumption. So it is supply independent, and there the oxygen depth is 0 and increased oxygen extraction is not there. It is at that critical point. If you will going to provide oxygen delivery below that critical point, then definitely it will be supply dependent. That is how much oxygen you will going to supply, it will be consumed. It is in the normal circumstances, but if you will going to see the pathological in a state of shock, or in a state where the metabolic demand of the child is being increased, as in the ICU patients, you can definitely see that in that way it is linear, and the critical point goes up and to the right, and it increases. It not on, by increasing the oxygen delivery, it does not reach a critical point, and it continues to increase until you will going to reach a critical point, and the critical point is being shifted usually up and to the right somewhat here. That will shows that these patients will require more oxygen delivery to these patients. That is enough. You need to increase the oxygen carrying capacity of these patients, as well as you need to improve the cardiac output in these patients to meet that oxygen demand which these patients usually develop. So you can imagine the amount of oxygen which is being provided, oxygen consumption, if you were going to consider that you are being able to meet at this oxygen delivery in a pathological state, you need to provide them more oxygen delivery to these patients to achieve the same amount of oxygen consumption which they usually have, and sometimes even more than that. You need to improve oxygen delivery in these patients so that you can reverse the shock and you can reverse their pathologic process. Another important concept is the oxygen extraction. That is how much fraction of oxygen delivered in the blood is actually being utilized or consumed by the tissue, organ, or the entire patient. That is how much oxygen is being extracted from the oxygen which is being delivered to the tissues or to the body. And in the fraction of arterial oxygen content that is consumed as the blood transfers to different organs, you can see that the heart is the most heart is the organ which extract the oxygen most. That is 70 to 80% of the oxygen is being extracted, and that is why if you are going to take the blood through the coronaries, its venous saturation is around 20-30, not more than that. The same is true with the brain. It consumes 60 to 70% of the oxygen that is being supplied to the brain. It usually extracts that. Then it depends on the muscles. But however, for the muscles, it depends on in an exercising muscle, it is much more than that. However, if it is in the resting state, it is 20 to 30%. In the liver, it is 25 to 35%. The kidneys are the least, it is 10 to 15%, and skin is 25%. At rest and higher levels, when the body is cooled or blood flow is redirected to other vital organs, as in the case of shock, the blood is redirected to other organs. So definitely the extraction ratio increases during that time period. And if you wanted to calculate it you can even calculate it if you have the arterial oxygen carrying capacity, if you have a venous oxygen carrying capacity, and you can divide it with the arterial oxygen carrying capacity, you can have that extraction ratio, that how much oxygen is being extracted through that. Agar aapne heart ka malum karna hai, you can take the arterial saturation, you can take the venous saturation to the heart, and you can take out how much oxygen is being consumed. The same is true with the brain, the same is true with the muscles or any organ. You can look into how much oxygen is being consumed by each and every organ. Or if you wanted to look into the entire body, you can definitely look into the pulmonary artery, where all the blood is being venous blood comes, and you can take the arterial sample as well from the aorta or from the arterial blood sample, and you can take out how much oxygen extraction ratio of the body is. You can calculate it easily from that perspective. So in a nutshell, the choice of oxygen delivery depends upon the patient's condition, how much oxygen is being requirement, and what healthcare setting you are working in. And oxygen delivery in various medical condition settings to treat the condition where there is a deficiency of oxygen in the bloodstream or tissues such as respiratory illness, trauma, or surgical recovery. There are several methods and devices used to deliver oxygen to the patient depending on their needs and severity of their condition. So in conclusion, it is really important to understand the concept of oxygen delivery, concept of oxygen consumption, concept of oxygen extraction, oxygen carrying capacity, and the choice of oxygen delivery depends on the patient condition, as I have discussed. It depends on the oxygen requirements, and it depends on the healthcare setting. Assalamu alaikum. My name is Dr. Naveed. I am working at Afghan University Hospital as pediatric intensivist. And in the next 30 to 40 minutes, I will be discussing about respiratory failure and oxygen therapy in hospital. Starting with the name of Allah Almighty. Bismillahir Rahmanir Rahim. And I don't have any disclosures. In the objectives, we're going to first discuss about the respiratory distress and respiratory failure, recognize the signs and symptoms, differentiate between respiratory distress and respiratory failure, and identify the respiratory problems, type and severity, and as well as how to manage these respiratory problems, and to review the mode of oxygen delivery to these patients. It includes an overview, definition of different terms, why the children are prone to respiratory failure, include the signs and symptoms, classification by severity and type as I have discussed, include the monitoring, management of these patient oxygen delivery in hospitals, and key points. So acute respiratory failure is a major cause of morbidity and mortality in the PICU. It accounts for 50% of the PICU admission, and therefore early recognition and urgent institution of the treatment is of paramount importance. For the respiratory failure definition, it has been defined as unable to deliver adequate oxygen supply to the body, or inadequate removal of the oxygen from the body, or the combination of both. And if we're going to look into the lab parameter, usually the blood gases will going to show the partial pressure of arterial oxygenation less than 60, and partial pressure of arterial carbon dioxide more than 50, which shows inadequate oxygenation and ventilation respectively, and it can be the combination of both as well. So remember, one should not depend on the ABGs to assess the severity of respiratory distress, and one should not depend upon the ABGs to initiate the immediate intervention. one should depend on their clinical assessment. Always interpret the EBGs in the light of your clinical assessment. Don't underestimate your clinical assessment. Whether you have to advance the non-invasive ventilation, whether you have to advance the invasive ventilation, whether you need to intubate the child or not, it all depends on your clinical assessment, not on the ABGs. So it's your clinical assessment mainly that guides you what needs to be done further, and we're going to discuss how you are going to clinically assess these children. Why are children prone to develop respiratory failure? It is because they have larger tongue and a smaller oral cavity and a larger tongue. The pharynx is smaller, the epiglottis is larger, and then the larynx is more superior and anterior, and it is most narrowed at the cricoid cartilage, and trachea narrow, and it is less rigid. And if we're going to look further, adults have a cylindrical shape trachea and larynx, while if you were going to look into the infant, it is funnel shape, it is narrowest at the cricoid cartilage, and it is much lesser diameter of the trachea. So therefore they are more prone to develop upper airway obstructions. For the physiological considerations, it is the children have higher minute ventilation, that they have higher respiratory rate, they have a smaller tidal volumes, they have a smaller FRCs as compared to the adults, they have a smaller reserves, and they have higher oxygen consumption. That's why they need to breathe at a higher rate in order to have that oxygen demand compensate with it. And they have reduced FRC, they have reduced tidal volumes, they have elevated closing capacities, which prone them to collapse their lungs, and they have faster desaturation as they have decreased oxygen reserves. So they desaturate faster, they because they have decreased oxygen oxygen reserves, and they have a higher oxygen consumption. That's why they desaturate faster. Considering the airway resistance, now this is one of the diagram which shows if the similar amount of airway resistance occur in the adult, it does not have that much amount of resistance, but if it occur in the infant, it can lead to significant 16-fold increase in the resistance, leading to less than 75% of the cross-sectional area. That is really important when you are intubating the children, especially smaller infant, and you do it multiple times. That lead to edema, and that can further lead to a significant increase in the airway resistance, and that can impede the air gas exchange in these patients. Considering the amount of grading of respiratory distress, that is really important to understand how you can identify that clinical distress and how you can meaningfully convert it into how much need of the patient is. That is, whenever the child has increased metabolic demand of oxygen, or whether it is mainly related to the sepsis or any other condition that lead to increased metabolic demand, increased oxygen requirement, or it is related to the lung disease itself, that the gas is not being able to exchange whatever the gas has been inhaled, the patient is not being able to exchange the gas because of the lung diseases, either due to collapse or due to the lung tissue disease, due to which the first sign you will going to see them is increase in the respiratory rate, that tidal volume remains same, but respiratory rate increases, the patient becomes tachypnic. That is the first initial sign that in which you need to identify that there is a pathology that has been ongoing, either the lung pathology or either the systemic pathology that has been ongoing. Then if the patient does not improve and the gas exchange does not improve, body sends a signal to the to the respiratory muscles, that is the diaphragms, to cause more vigorous contraction such that to improve the tidal volume, so that one can improve the minute ventilation. And it is this minute ventilation, this increase in the tidal, in the quest of increase in the tidal volume by the diaphragms, by that cause that you can see it as a retraction, that is subcostal retractions occur, and if that does not fulfill the oxygen demand, then the signal goes to the brain and intercostal muscles start to work, suprasternal muscles start to work, and then nasal flaring and head bobbing. Remember, nasal flaring occur as a part of physiological response to decrease the airway resistance, as 40% of the airway resistance occur in the upper airway, and in order to release that, in order to improve that, these nasal flare that increase in size, so that airway resistance decrease in these patients. And these are all hallmark sign of severe respiratory distress, that is subcostal recession, intercostal recession, nasal flaring, head bobbing. These are severe signs of distress, and that's how you can differentiate it. If it is only mild tachypnea, no work of breathing, this is mild respiratory distress. If there is only subcostal recessions, this is moderate respiratory distress. But if there is subcostal retractions, intercostal retractions, nasal flaring, the child is in imminent respiratory failure. And grunting is also one of the physiological response in which the child develop PEEP. That is when the patient breathes against the closed glottis and the child develop a sound like develop a sound like or sound of grunting, in which they usually breathe against a closed glottis, and that develops that provide a PEEP within the lung in order to improve the oxygenation, and that is these are the impending sign of respiratory failure. However, other signs like cyanosis, these are pretty late sign. Apnea, this and bradycardia, these are pretty late signs. And if you were going to look into the signs of respiratory failure, marked tachypnea, as I have mentioned earlier, this is an early sign. Bradypnea, which is the bradypnea, and apnea, which is a late sign. Increase, decrease or no respiratory effort, this is a late sign. Poor or absent distal air movement, this is a late sign. Cyanosis is a late sign. Marked tachycardia is an early sign. However, bradycardia, irritability, anxiousness is an early sign of hypoxia, brain hypoxia, so you can detect it early. However, stupor, coma is a late sign. So as it is mentioned, these signs are the CNS and CVS signs of hypoxemia. So a patient does not go directly into severe respiratory distress. They usually develop mild respiratory distress, then moderate respiratory distress, and then they usually develop severe respiratory distress with impending signs of failure, which lead to respiratory failure. And it is this respiratory failure and respiratory distress which lead to cyanosis and CNS and cardiovascular signs of hypoxemia, further leading to multi-organ dysfunction and leading to death of the child. There is how to differentiate between the respiratory distress and respiratory failure. That is, usually it is extremely important to differentiate because if the patient go into respiratory failure, it is within minutes that they can go into cardiac arrest. Usually if the patient is in distress, it usually take hours to go into respiratory failure. But if the patient is in failure, it usually take minutes for the patient to go into cardiac arrest. So it is really important to identify the patient early during the time of distress, to intervene in this time period so that you can prevent them going into respiratory failure and developing the cardiac arrest. So this is another schema which we have taken it from the PALS algorithm, and it shows that any precipitating effect, whether it is respiratory, circulatory, or it can lead to respiratory distress, it can lead to respiratory failure, and any shock can lead to cardiopulmonary failure, and that can lead to cardiac arrest. Most common cause of cardiac arrest in children are due to respiratory, that is hypoxia, that they develop hypoxia, they develop respiratory distress, respiratory failure, and then they go into cardiopulmonary failure and cardiopulmonary arrest. That is most common cause of cardiac arrest in children. So what are the signs of respiratory distress and respiratory failure? How do you can differentiate it? That is, if the airway is patent and maintainable, in the respiratory failure it is not maintainable. In the respiratory rate, they are tachypnic, they are bradypnic or apneic in respiratory failure. Work of breathing, there is increased work of breathing, that is with respiratory distress, nasal flaring, retraction. These are imminent sign of respiratory failure, but they are signs of respiratory distress. However, if they have developed decreased efforts or they have become apneic, then these are signs of respiratory failure. There is a good air movement, you can hear it with the stethoscope, and definitely these are the signs of poor. However, if there is no air movement, poor to absent, then these are the signs of respiratory failure. If the patient is tachycardic, this is an early sign of failure. However, if the patient is bradycardic, then the patient is usually in respiratory failure. If the patient is cyanose, that is a sign of respiratory failure. If the patient is anxious or anxiety or agitated, and that are early sign of hypoxia to the brain, you can detect them early. However, if the patient is lethargic and unresponsive, these are late signs of respiratory failure. And then glucose can be variable and exposure temperature can be variable. As per Pyle's algorithm, one need to have an initial impression, that is consciousness, breathing, and color. You can just see by looking at the consciousness, breathing, and color, looking at the patient, you can identify whether this is a life-threatening problem or not, whether the child has breathing, how is the child color, is the child is cyanose, is the child is pale, is the child is normal. Then you need to evaluate them with a primary assessment, secondary assessment, diagnostic tests, and identify by severity and type, and then intervene accordingly, according to what you have identified. So in the primary assessment, after the initial assessment, there is airway, breathing, circulation, disability, and exposure. And in secondary assessment, there is focus history, that is sample history, and focus physical examination. And then moving on to the diagnostic tool. We're not going to go into the detail of these as it is a part of Pyle's, but we need to go through a systematic approach. However, at any point in time while you are doing, if there is any life-threatening situation, then you need to start CPR right away. If there is no breathing, if the patient is cyanose with no breathing, if the patient is having pulses but child is cyanose, you need to start bagging right away in those patients so that you can match the gas exchange. You can improve the gas exchange in these patients. So after the life-threatening problem, you need to go through the airway breathing, that you need to make sure that the airway is complete, airway is patent and secure. If there is severe airway obstruction, you need to release that. If there in the breathing, you need to look into if there is apnea, significant increased work of breathing or bradyapnea. You need to look into circulation, that is absence of pulses, poor perfusion, hypotension, and bradycardia, and you need to treat them accordingly. If the patient is unresponsive in disability or decreased level of consciousness, you need to monitor them and provide adequate support. And if in exposure, if the patient is significantly hypothermic, if the patient is bleeding, having petechiae or purpura with septic shock, that gives you the clue to give the antibiotics and give the blood products to these patients. Coming on to the types of pulmonary diseases, and according to the Pyle's classification, in the upper airway obstruction, if you are suspecting there is upper airway obstruction, you can consider croup, anaphylaxis, or aspiration of foreign body. If there is a lower airway obstruction, you can consider bronchiolitis, asthma. If there is a lung tissue disease, you can consider pneumonia, pneumonitis, chemical pneumonitis, aspiration, or infectious pneumonitis. It can be pulmonary edema, either neurogenic or cardiogenic. It can be disordered control of breathing that occurs in increased ICP, neurological disorder, neuromuscular disorder, or it can be due to poisoning or drug overdose with respiratory depression, and that can lead to disordered control of breathing. What are the other examples of upper airway obstruction? As we have discussed, it can be epiglottitis, tracheitis, laryngotracheomadesia. These are the other infectious causes. In the lower airway obstruction, it can be asthma, bronchiolitis, and cystic fibrosis, as we have discussed. In the restrictive lung disease, it can be in the lung tissue disease, it can be acute respiratory distress syndrome, pneumonia, pleural effusion, pulmonary edema, and abdominal compartment syndrome, causing the diaphragm to move up and having restrictive effect on the lungs, leading to respiratory failure. In the CNS disorder, it can be intracranial injury, hemorrhage, or ischemia. It can be medication or sedatives. It can be metabolic encephalopathy like hepatic encephalopathy or any other encephalopathy. It can be peripheral nervous system disorder or muscle tissue disease, muscle disorders like Guillain-Barré syndrome, muscular dystrophy, scoliosis, spinal cord injuries, botulism, and intoxications like organophosphorus poisoning. So coming on to the different signs of respiratory problems now, through which you can identify whether this is an upper airway, lower airway, or disordered control of breathing. There are several signs which you can identify during the examination, and you can differentiate it whether there is for example, in the upper airway obstruction, you can hear the stridor. There is increased work of breathing in all the cases. However, you can hear the stridor in the case, you can hear the barking cough, you can hear the hoarseness of voice in the upper airway obstruction. In the lower airway obstruction, you can hear the wheezes, whether it is expiratory, whether it is prolonged expiration, whether it is both inspiratory and expiration. In the lung tissue disease, you can hear the crackles, decreased breath sounds, and grunting. Air movement can be decreased in either direction. Heart rate can be tachycardia in early phase, bradycardia in the late phase. Skin, it can be poor, cold, dry in the early, but it can be cyanose in late stage. In level of consciousness, as we have discussed earlier, it can be anxiety and irritability in the early stage, and lethargy and unconsciousness in the late stage. So these are the signs. If you're going to go through the sequential approach, you will be able to find out what sort of problems, type of disease the child usually have. Common causes of hypoxiatis. This is the most common cause of cardiac arrest in these patients, and respiratory failure can be a common cause hypoxia hota hai. So how can that occur? It can occur due to hypoventilation, like if the patient does have intoxication and they have taken any drug, that can cause respiratory depression, that can cause hypoventilation. If the patient have any central nervous system disease, that can cause hypoventilation, or so these are the common causes. If the patient have any shunt lesion, that can cause hypoxia. It can be physiological shunt in the lungs, like lung collapse, or it can be any shunt disease, AV malformation within the lungs. It can be ventilation perfusion inequality that occur commonly in the pneumonia. It can commonly occur in the lung collapse. It can commonly occur in the ARDS, and ventilation perfusion inequality mismatch is the most common form of hypoxia in children. Diffusion limitation in terms of edema, if the patient has pulmonary edema, if the patient has any pneumonitis, or if the patient has develop barrier within the alveoli that causes limitation of the gas exchange, and that is a diffusion limitation. And low inspired fraction of oxygen as occurring at the higher altitude, or in the cases of fire, when there is a burn, when patient inhale smoke, and that can lead to low inspired fraction of oxygen and carbon monoxide poisoning in those patients, and development of hypoxemia. What are the common causes of hypercarbia? It can be either decreased ventilation, decreased tidal volumes as occur in the sedative overdose like benzoids and opioids, or it can be neuromuscular disease like central nervous system disease, spinal cord, peripheral nervous system, or other diseases, and frial chest post-trauma, or it can be due to increased dead space ventilation like hyperinflation as occur in obstructive airway disease like asthma, bronchiolitis, and cystic fibrosis, or if you are providing excessive PEEP on the mechanical ventilation, that can lead to compression of the vessels of the lung and decreased lung perfusion, which can you are providing adequate ventilation, but you are not being able to perfuse the lungs. So in order to perfuse them nicely, you need to decrease the PEEP in those patients. If there are issues of decreased cardiac output in any case of shock like dehydration, in hypovolemic shock, dysrhythmias, in cardiogenic shock, myocarditis, in post cardiopulmonary bypass, increased pulmonary vascular resistance in the cases of pulmonary hypertension, that can lead to decreased perfusion. It can lead to definitely increased dead space ventilation, and sudden cardiac death in these patients due to decrease in cardiac output as well. Also pulmonary embolism, that can lead to increased dead space ventilation and decreased perfusion to the lungs. So what are the monitoring protocols? That is, as we have discussed, you need to monitor the heart rate, rhythm, depth of respiration. You need to monitor the heart rate, blood pressure, and temperature, presence or absence of cyanosis, use of accessory muscles as we have discussed it in detail. air entry in both the lungs, endotracheal tube position, patency, need for suctioning if needed, if it has been blocked, sign of exhaustion like somnolence, confusion, and seizures, non-invasive monitoring like saturation and EtCO2, and ABGs must be interpreted together with the clinical assessment of these children. So, coming on to the management part, its initial management is the airway, breathing, circulation. That is pretty important, and specific management for these respiratory failure patients. So before moving forward, we're going to discuss about airway, breathing, circulation, what pertinent urgent resuscitation needs to be done in these patients. For the airway, you need to do the open the airway, head till chin level or jaw thrust in the case of an head trauma or cervical trauma, and you need to clear the airway by suctioning or by inserting the oral airway, or if there is a foreign body is there that needs to be removed, you need to insert oropharyngeal or nasopharyngeal airway. If the patient is not being able to maintain their own airway, then you need to maintain it by inserting airway adjunctives. If for the breathing, you need to monitor the saturation by pulse oximetry and provide oxygen if available using high oxygen concentration, that is high flow oxygen needs to be given to these patients either through the high flow or through the non-rebreather mask, and so that you can provide them 100% oxygen. Administer inhale medications, and if needed, if they have wheezing, you need to administer albuterol or epinephrine as needed. Assist bag and mask ventilation. If they are in failure, you need to assist them with the bag and mask ventilation and provide endotracheal intubation if indicated. And in the circulation, if the patient is in, if the patient has vascular access, you can give medications and fluid therapy as needed. For the management of as you have done the airway positioning, suctioning, oxygen is given, you have monitored and BLS as indicated, then according to the need, if whatever the type of respiratory illness is, you need to then monitor the upper airway obstruction. If there is upper airway obstruction, you need to then identify whether it is due to croup. If it is due to croup, you need to give corticosteroids and nebulize epinephrine. If it is due to anaphylaxis, you need to treat them accordingly by the antihistamines, corticosteroids, and epinephrine. And if it is aspiration, you need to allow position for comfort, and a special consultation needs to be given. If there are low airway obstruction, then you need to give bronchiolitis. Then you need to nasal suctioning, bronchial dilator trial needs to be given. If there is an asthma, then definitely you need to treat an asthma with the corticosteroids, albuterol, subcutaneous epinephrine, magnesium sulfate, and terbutaline infusion. So other than that, if there is a lung tissue disease, you need to treat them with the antibiotics as well as with the if there is chemical pneumonitis, you need to give supportive treatment. If there is pulmonary edema, you need to provide them diuretics. You need to consider vasoactive support, and you need to consider non-invasive or invasive ventilatory support. If there is a disorder control of breathing, then definitely you need to provide neuroprotection for avoiding hypoxemia, avoiding hypercapnia, and avoiding hypothermia. If there is poisoning, and a specific antidote needs to be given. And if there is neuromuscular disease, you need to provide non-invasive or invasive ventilation accordingly. So the choice of oxygen delivery depends upon the patient condition, oxygen requirement, and healthcare setting where you are coming. And oxygen delivery, as we have discussed in the previous session of oxygen support, that it depends on the respiratory illness, trauma, and how much oxygen deficiency has been there in the bloodstream. And there are several methods and devices used to deliver the oxygen to the patient depending on their need and severity of the condition. So oxygen cylinders are one of them. Oxygen cylinders are portable tanks filled with compressed air. They are commonly used in hospitals, clinics, and ambulances, and it can deliver through the oxygen to the patient through a flow meter. A delivery device such as nasal cannula or oxygen mask or high flow nasal cannula can be attached to these oxygen cylinders. So oxygen concentrators are devices that extract oxygen from the surrounding air and concentrate it within the machine and deliver it to the patient. And they are often used at home settings and can provide continuous flow of oxygen. And concentrators are more cost effective and convenient for long-term oxygen delivery rather than oxygen cylinders. So liquid oxygen systems, liquid oxygen system stores oxygen in a cryogenic liquid state. These systems primarily used for patients who require high flow oxygen for extended period, and liquid oxygen is converted into gas for delivery of to the patient. Oxygen tanks, they are the reservoir, large reservoir bags. They are often used in conjunction with the mechanical ventilation, and these tanks store a large volume of oxygen that can deliver it to the patient with specific respiratory needs, such as during the surgery or in the ICU. These can be used. For the oxygen generators, oxygen generators can produce medical grade oxygen on site using room air as a source. They are particularly useful in healthcare facilities where continuous oxygen supply is required and eliminate the need for oxygen cylinder storage. Nasal cannulas are the lightweight, flexible tubes with the prongs that are inserted into the patient nostrils. They are often used for low to moderate oxygen flow rates and are well tolerated by the patient for long-term oxygen therapy. Flow rate that is typically ranges from 1 to 6 liters, and FiO2 ranges from 24 to 44 liters depending on the amount of oxygen provided. For the oxygen mask, they cover the nose, mouth, and deliver the higher concentration of oxygen than the nasal cannulas. They are typically used when higher oxygen flow rate are required and higher oxygen concentration is required. And there are different type of masks that can be used. That is an oxygen simple face mask that usually require a flow rate of 5 to 10 liters per minute, and approximately 35 to 50% of oxygen can be given from that. Partial rebreathing mask, which with a flow rate of 6 to 10 liters per minute, it provides 60 to 75% at 10 to 6 to 8 liters per minute. Non-rebreather mask with a flow rate of 10 to 15 liters, it provides 18 to 90% of oxygen through 10 to 15 liter of oxygen. And Venturi face mask, it is color dependent, 4 to 10 liters, and it precise adjustment ranges from 24 to 50% or higher depending on the adapter use, what kind of device you are using according to the color. Then the high flow nasal cannula, it is a specialized nasal cannula, provide higher flow of humidified oxygen. It is used for the patient who require precise control of inspired oxygen and flow rate. That is, you can give 21% oxygen in these patients as well with a flow rate up to 60 liters. FiO2 can be provided at higher level at 100% and can be lower at 21% while delivering high flow rate of humidified oxygen. So for the non-invasive positive pressure ventilation like BiPAP and CPAP machines, it can be used to deliver positive pressure through the either face mask, through either nasal mask, or through the whole tented face mask, and they are commonly used in sleep apnea treatment and other respiratory conditions, chronic respiratory conditions which require home treatment. And the flow rate and settings are specific to the device and patient needs, and the FiO2 can be adjusted and mixed with the room air as needed to achieve the desired oxygen concentration which is being required. So ventilators, they assist or completely control the patient breathing, delivered a mixture of oxygen and air at a controlled pressure and rates, making them essential for the patients with severe respiratory conditions or undergoing surgery. So the flow rate in ventilator deliver oxygen at specific rates and pressure described by the healthcare providers. FiO2, one can control it from room air, that is 21% to 100% in these patients. So Coming on to the key points, always follow the PALS algorithm guidelines. Children are prone to develop respiratory failure because of the airway, because of their decreased reserve. Therefore, you need to identify immediately, intervene immediately and effectively. And before it go, and you need to identify them in respiratory distress rather than before it will going to progress to respiratory failure and cardiac arrest. X-ray is not mandatory in the initial stage for most of the cases. You need to take the decision on clinical ground, and ABGs are not mandatory to assess the severity of the pulmonary problem and to initiate urgent intervention. All the things needs to be graded on initial ground clinical interpretation. Manage and restore airway breathing circulation, provide high flow oxygen, immediate management for a specific problem like intubation, tracheostomy for upper airway obstruction, needle thoracotomy or drainage of the pneumothorax, first dose of antibiotics for the febrile child, and define detailed clinical assessment to localize the disease illness, whether it is respiratory, it is cardiovascular, or it is CNS, and specific investigation needs to be done in terms of from that standpoint. That is whatever your treatment needs, as we have discussed in the PALS algorithm. Just one thing that whenever the patient goes into respiratory failure and the patient requires intubation, there are only 3 causes. Either it is respiratory, either it is cardiovascular, either it is CNS. There are no 4 causes that can cause intubation or respiratory failure. So the key point from the choice of oxygen delivery depends on patient condition, oxygen requirement, and healthcare setting where you are, and what are the resources available for that purpose. So thank you very much, Anna, for being so patient, and we're gonna thank you.